here, and staff. And so we have a very large pile of documents, all of that, which we're not going to look at, which will probably tell us how much you earn and how many positions and so forth. But I think what we'll look at is really, well, I don't know, you have ups and downs and you have a lot of other material. So I'm going to leave it to you to extract for our benefit. And maybe it's this document here that we should look at first. I'm not sure.
No.
So why don't you?
So here's, I'll help you.
Well, I'm actually, I want to defer to you in terms of how you want to present your budget, and we won't hold to the script anyway, so don't worry.
All I wanted to do initially, because you have new members, is give them a little orientation to our department.
And so, you know.
Although some of them, even though they're new members, more than know my department.
Really old. And Senator Berkeley is new, and he's vice chair right here.
Okay.
And Senator Sears is out, he's ill. And then, of course, our pro tem is in that empty chair, and he's on his way, or he'd probably be in California now for his daughter's wedding. So,
Can I run over to finance? They're just taking up a bill. If they have any questions,
Yeah,
it won't be long.
all right, so we still have a quorum, so why don't you?
Yes, I'll just go quickly through some of the introductory stuff. Much of the ups and downs stuff is very brisk, simple. And
Do you have
then
an ups
there's
and down sheet here?
on the,
Yes, it's in the
yes.
packet.
And then there's a few areas you probably want to discuss more, which we can listen to. Okay.
Let's see. Well, this is the explanation. I was looking for the ups and downs sheet.
Now, the ups and downs is kind of sprinkled through the presentation by appropriation.
3 ups and downs
Yeah.
sheets. 3 appropriations. But they all look like this.
All right, well, why don't you proceed however you want to
Okay.
give us the diagnosis.
So I just want to welcome people to the Department of Health, so you can learn a little bit about us and put the budget in the context of that. Our mission is to protect and promote the best health of all Vermonters. Forward. We do that through a whole host of mechanisms. This slide is pretty illustrative of how we interact with the healthcare system, how we try to actually improve the lifestyle behaviors of the population, how we hope they will benefit from wonders of modern times like immunizations and ability to screen for a variety of conditions that knowing about early is better, so that we can intervene and have a better outcome. Just because this is not a healthcare committee, it's necessary to explain that only 10% of health is determined by healthcare. Health being defined as sort of that constellation of physical, mental, emotional, spiritual well-being. That is the way we generally want to feel, free of illness. Most of what determines health, not being healthcare, is lifestyle behaviors and the socioeconomic status and environmental status of the surroundings we find ourselves in or we may be born into. Looking at what has the most impact on health and least impact is important for our conversations here, because unlike my life in clinical medicine, which was the top 3 rungs of this health impact pyramid, the bottom 2 rungs are the most important for today's discussion. So yes, we do a lot of counseling in medicine and educating. We intervene on chronic conditions. We try to keep people healthy by making sure they are up to date on their screening tests and immunizations, etc. But the largest impact is actually what public health does in the bottom 2 rungs there, changing the context to make the individual's default decision the healthy decision. So buying a box of crackers that is free of trans fat, you don't have to make a decision anymore because they're all free of trans fat. If you want to sit in a restaurant and not get lung cancer from secondhand smoke, you don't have to actually make a major decision there because we've mandated that you shouldn't be smoking in restaurants. If you want to keep the population from acquiring the expense of tobacco-related diseases, you make it more expensive for them to buy cigarettes, which we've done over many years, successively increasing taxes on that. If you want their teeth to be healthy, you advocate for fluoridation of their community water. And if you're fortunate enough to grow up in a community that has that, you won't have to do too much else other than brush your teeth.
You know, it's interesting because some of these basic public health initiatives are now under attack.
So
They are.
Oh.
I'm talking about many, certainly immunizations.
Yes.
And then of course, fluoride in the water. So it's interesting. I think to some extent that, you know, if you've got a long memory or you predate the immunizations, you know what it's like, and you know what happened when we had whooping cough, and we had measles, and we had mumps, and all of the above, and it's been so long, and so people are conflating. I eat healthy. I have a healthy environment. Therefore, I am immune
Yes.
to those childhood diseases, and so it's interesting to see today the extent to which some of those very basic public health measures that have been behind a significant improvement in health status are under attack or
Yes.
Being discredited.
We live in very
So that must
fractious
pose very,
times.
and obviously on the adverse reactions
Yes.
for particularly on the COVID
COVID
vaccine that
vaccine.
we got.
Mhm.
And people are saying, and you gave a very good background in terms of anybody can report, nothing is vetted. And so you can say somebody died, but there's, if you didn't know the limitations of that reporting system, how that data is being used is counter to really the whole.
Precisely.
And so it's kind of interesting, the environment in which you're doing your public health work, and the way in which information is coming in to influence people's attitudes toward public health that 25 years ago, 30 years ago, would never have been there.
Right, most people didn't even know the phrase public health back then, but they did know organizations.
That's right.
No, thanks. So
And
it's,
no, you point out my life today.
yeah, I'm sure.
And then the bottom part of this is the toughest socioeconomic factors. That means, do you have access to wealth? Do you have a roof over your head? Do you have food security? All of those things really are health. So we have numerous medical articles called "Housing is Healthcare," and it's so true. The reason many people who live in terrible housing conditions have diseases like diabetes and asthma out of control is not because they don't go to the doctor or try to do what the doctor says. It's because of their basic conditions of life that they're born into, grow up in, etc.
And those are systems that are external to the Department of Health, but they greatly influence.
They are what we do every day because.
But you're not in the
No.
business of building housing, so
No.
you really are dependent on
Yes,
communicating the importance of
exactly.
these
Working
factors
across
on
sectors.
overall health. Right. Well,
Exactly.
you know, John Muir said everything's hitched to everything else, and so that's what you're hitching here.
And I'll illustrate that in a slide or two. So these are the social determinants of which we just talked about. And our whole foundation in health now is health equity, meaning having a fair and just opportunity to be healthy, which is very different than just, saying Vermont's one of the 3 healthiest states in the country. Well, that's true. On average, everybody looks really healthy. But when you start digging down into different categories, looking at populations based on race, based on gender orientation, based on disability status or socioeconomic status, you find there are many historical injustices and disadvantages that determine why someone is or isn't or can or can't be healthy. And the picture shows health equity very nicely in the middle platform, but really there's still barriers to viewing this event well. On the right-hand side, the barriers, think of them as systemic barriers, have been removed.
You know, and I've mentioned this to the committee, and you probably read it, the article in the College of Medicine around Abraham Flexner and his work at the turn of the century, and the impact of his recommendations, if they were accepted, on our healthcare of today, in terms of physicians of color and the colleges that were shut down that educated those practitioners, that many of whom would have gone into primary care, constricted the supply, et cetera. So it was very fascinating. And the same thing has happened with nursing. And all our hospitals used to have nursing programs, and they would actually educate and train their own workforce. And then we moved to a more academic focused model, constricted the number of students, and see what we got ourselves into. So much of our decisions that were made in the past, how they're influencing our health care challenges of today, are really very, very striking.
And if you looked at public health just 5 years ago, you wouldn't see the emphasis on health equity there is today. It's like it's been rediscovered. And it is probably the most important thing you talk about. So our state health assessment basically told us that we need to focus on child development, chronic disease, mental health, substance use, and oral health in the context of the social determinants of health. And that's exactly what we're doing, making sure we focus on the right populations where people don't have the same opportunity, fair and just, to be healthy. So very briskly, here's what our department looks like. I'll go through each division one by one. We have environmental health, which is just what it says, taking full stock of the fact that we've trashed the environment we call Earth. And we have lots of issues to deal with, but we deal with them. So whether it's lead in the drinking water of schools or lead in the paint of older housing stock, we understand what to do about that. Whether it's how safe is our food supply and our water supply, and most importantly nowadays, what impact is climate change having on health, and what will it continue to have on health, and how do we need to plan appropriately? That is the work of our environmental health division. Maternal child health is a division that's very traditionally public health, because if there are two things we know. One is that what happens in your very, very earliest, most formative phase in life, it's often what determines the rest of your life, how successful you may or may not be. And the second thing is social isolation is a terrible thing. And most of the bad behaviors people start to practice over the course of life, often they emanate from having a period of social isolation. So maternal child health really works on that pregnancy period, because so much goes wrong at that time in our
You know
Vermont
exactly what I'm
population.
thinking.
I know.
They also focus on early school years.
I'm thinking about our
Adolescent.
smoking rate of pregnant women, which
Yes.
has been historically
Which we've been
high.
after for.
Smoking rate, cannabis use rate, alcohol use rate, opioid use rate. That's one of our most vulnerable times in life in our Vermont population.
And we have not bent the curve on smoking.
We've bent the curve, but we've got a long way to go.
Insufficient.
Yes, we've got
Well,
a
I
very
don't know,
long way.
last I knew, we were #1 in the wrong place.
Yeah, so
in terms
these
of our
are,
smoking
We
rates.
have enough.
Well, we haven't.
we have
We do have enough.
And it just wondered, because if we're trying to make sure that all our mothers have access to prenatal care and through coverage, and it's like, how do we somehow it's not, they're having contact, they're not arriving at the hospital, without some contact. Why we haven't been able to intervene at those points of service to.
And that's why we spend so much of our time on home visiting programs, right at that critical time in life when the child is first born and the postpartum period.
Well, if the mother's smoking before, she's smoking after the child's born, so.
Well, but you'd be surprised what we can do in that time period. And you'll hear during the budget presentation a little bit about a program that embeds a family specialist in a pediatrician's office that can be very effective at working on the social determinants of health at that stage. You've also had lots of experience with after-school programs for adolescents. That really came from our maternal child health sort of orientation. And that's where the WIC programs are for nutritional guidance. Laboratory science and infectious disease is epidemiology, essentially. It's what you heard about with the COVID pandemic, but it's so much more than that, because that's not the only infectious disease out there, nor the only vaccine out there. And we also have a public health lab illustrated here, which is in Colchester. Substance use programs you're going to hear a lot about at the end of our budget presentation, mainly because of the crisis in opioid overdoses. Clearly, we have a substance use programs division that tries to deal with substances across
And
the
we did,
continuum.
in our public hearing, we heard from our recovery centers and what they requested, which was 1.8 million increase in the base and $1 million for housing.
Yes.
But
You'll
that's not
continue
in the
to.
budget. It's not in the budget. You're
There's some in our budget that we're going to do.
to the recovery centers.
Not to the centers themselves, but recovery beds, recovery sobering beds, things of that sort. Local health is just to illustrate that though we have a centralized operation in Vermont, we do have district offices that really are the boots on the ground across the state. Health promotion and disease prevention is really, my career was in internal medicine. I treated all the chronic diseases that you can think of, and it'd be nice to prevent them. And so many can be prevented through lifestyle change. We can also manage them better through self-management programs, which we also do within our health department. And though I showed the emphasis on maternal and child health, I've tried in my tenure to focus public health as much on healthy aging as that end of the age spectrum, because whatever is good for somebody who's aging is good for everybody who is younger than that as well, whether it's the design of a community or a program. And then the other thing you heard about during COVID, of course, was emergency preparedness and injury prevention, just responding to whatever disaster we have, as well as trying to prevent things like falls in the elderly, suicide. And then because we are a data-driven operation, health statistics and informatics is a core part of what we do, not only in disease registries, but in vital records and in all of the data that we kind of have that Vermonters submit to us through surveys, etc. So post-pandemic, we're going to be focusing a lot on the things on this slide because they all existed pre-pandemic, but they have been exacerbated and put on the front page of the newspaper consistently, whether we're talking about mental health, suicide, chronic disease, social isolation, substance use, educational setbacks of our youth, and health debt, which means accumulating bad behaviors, especially during the time when everybody was isolated, stay home, stay safe, and maybe never gave up those bad behaviors. So our emergency rooms now are full, and they are always full of people with chronic diseases that have either just presented or are exacerbated because of the debt in terms of what we're paying for over a 3-year pandemic. Some themes you'll observe in the budget that are clearly relevant, obviously the preserving our children's brains part. In this case, we're dealing more with PCBs than anything else, but at the same time, we have a Substance Misuse Prevention Council, and the whole process of recovery from COVID is focused, much of it, on kids. I mentioned the program in pediatrician's office. It's called Dulce, and it's part of an initiative that you'll be hearing about that really connects people who have issues with the social determinants part of the equation to the resources they need.
Well, we've had a lot of discussion on that because our concern is the experience Vermont has rate of young children being brought into custody of the state because of
Yes.
the care, and how we can somehow not be an outlier, because we always thought we were doing a pretty good job with the support services, and then to find out that we are, so far apart from other states in terms of the children that end up in DCF custody.
And this is as upstream as you can get. So that's the important thing. We are actually trying to anticipate those needs and not have them require the needs because we've done such work upstream.
Now, is this the program that was developed in Australia?
No, that's MESH. That's part of the
MESH.
Universal Visitation
Oh my
Program.
gosh, and we had a battle on that, didn't we?
Yeah. But this is a relative, but this is a US developed program. called
So what
Dulce.
happened to MESH?
We're still doing it.
Are you still doing it?
Yeah, that's where nurse practitioners and or family specialists can do a visit at home. No, not every mother wants that. So it turns out when you embed this family specialist in the pediatrician's office, and the pediatrician does the handoff to the specialist, they can backdoor into the home visit, because then the home visiting becomes something that their practice office endorsed. And it becomes something that you can do even though you didn't start.
So what's the take-up rate?
So for our newborns in Vermont, about 95% of them actually are seen in the first 6 months
But
because they
how
have a
many-
medical home.
Right, but in terms of the
And-
home visit,
And for adults, well, for the home visits, I'm not sure, but for Dulce, the program we're talking about, it's over 90%. Because it's in the practice setting where they've trusted.
but we were hoping, and maybe we'll start seeing some of the data, because those were investments that we made that were recommended as part of our child welfare initiative.
Yeah.
And so,
Parent child centers as well.
and parent child centers as well, and we actually tied the increase to focusing on the families most at risk of children
Yes.
coming into custody. And so at some point, I think we're anxious to see, were those investments, what we saw for improvements, and are they measurable? And obviously the bottom line is children can remain safe and with their families, and
So
and
think
how
of it as a tripod. We've got the home visiting program, we've got this Dulce program, and we've got the parent-child centers. The family specialist who's in the Dulce program in the pediatrics office is an employee of the parent-child center. So it's directly.
program was in.
Mhm. Yeah, you were one of the pilots.
We were the pilot.
Yes,
Yeah.
we have 5 pilots. And the goal is to make this state.
In our family centers.
Yeah.
So I'll just quickly go through the last couple so we get you to the budget. Obviously, we've got intense interest still focused on the opioid crisis, which you'll hear more about. We continue to want to focus on kids' health and environmental health and climate change. And that brings us to the budget. And I could take a short break if there's other questions.
no, why don't we keep going?
Okay.
I know you're gonna get to it
Yeah.
probably, but that is the recommendations from the opioid advisory council on the millions of bucks of money into the state.
Yeah, it's not in the slides, but I'm happy to get to it.
Oh, okay, well, I don't wanna slow up this presentation.
We'll have,
Yeah, you and I should.
no, we'll have time,
Okay.
because there's a laundry list, as I would call it. So the main take-home message from the introductory budget slide, besides the fact that the service budget is fully funded and it has an overall increase of 5%, is that we have about 50% of our budget completely federally funded.
Yeah, we know you've
And-
always.
And we have a very small component that is GF, under 10%. Now, when you combine global commitment and GF, we're up to 30%. but still, our budget was a little different than many budgets in that regard. And we're up to the astronomical number that I can't believe of $217 million. And it wasn't too many years ago that I was always talking about a $150 million budget. And I would never have thought that would have grown way beyond inflation to this level. Now here we are, and it's a good thing for the state of Vermont. And it's a good thing the federal government did in providing us with some extra emergency preparedness money for staffing in areas of epidemiology, laboratory science, emergency preparedness, and health equity. Unfortunately, none of which is permanent.
I was just gonna say, so how much of this is gonna be is stable over time, and how much of it is?
So this is definitely stable till the end of 2024 FY, but we can't comment beyond that. It all depends on the US Congress.
Yeah, you look at that 108 and 55 global commitment. You know, you're talking 163 and 64 million. You're gonna have a pretty lean budget when that Fed money is.
Well, the big one is, but historically, you've relied on grants.
Historically, yes.
So the 108 is higher, but you've always.
That's public health in America. Yeah.
But so many states actually weakened or dismantled their public health infrastructure. So they came into the pandemic in a very different way.
So I'm going to now let Anna guide us through the ups and downs of the 3 appropriations: administration and support,
And I don't see.
public health, and
Where is
substance use.
Keep going here, and we'll come to it. Right here. Okay.
Yeah. Which is number 27.
Yep, so Anna Swenson, Financial Director with the Health Department. I'm going to walk the committee through more of the routine items in our ups and downs, the budget proposal. Dr. Levine will jump in as we get to more of the programmatic items.
And you don't need to do line by line. I just tell you that the
Yes.
House does, but you've got one here for $4,908. I probably don't want to spend a lot of time on that.
We appreciate
Because he
it.
understands how we work. So it's, and we'll probably not keep you to your script, but we really would like to know, I mean, often,
Yeah, no.
many things like, the internal service funds don't even bother with that. We know that those are billed and, so forth. So,
Just
well, pardon me. Yeah, okay. So.
We'll go as fast as you allow us to.
Well, I think the important thing is what is here that really you want to highlight that shows
Okay.
a particular emphasis or an initiative. There are certain things, we know you have to annualize your pay, benefits, et cetera. But what is it that is going to be, as you're looking at those goals and so forth, how does this budget connect in terms of investments or whatever? So.
We can do that.
Okay. Sure, so starting the administration and support appropriation, we're on page 27, as Dr. Levine noted. So in this appropriation, you pretty much have all routine or technical item adjustments. So you'll see your salary fringe, a technical adjustment for position fund splits. In that line item, we are just bringing the fund split for positions funded by department administration in line with historical actuals and what we expect. We have an adjustment to vacancy savings, retirement increase, a couple new positions in this appropriation, 2 new positions funded by federal funds. Those are limited service. The $4,900 line item is a position class action reclassification request.
And the big one is the scholarship removal.
And so then, so the main line item in this is a removal of a one-time appropriation. This was a one-time appropriation to temporarily increase the amount of that programming for scholarships for medical and nursing students. That was for 22 and 23, so those funds aren't available in 24. So this line item removes that funding from the budget for the 24 proposal. So that brings us to public health. Again, many of the same line items that we just saw in administration and support, routine increases, salary fringe, etc. The first, I guess, more programmatic item in this appropriation is a requested increase for the opioid antagonist program. The department distributes naloxone, which is a medication that can reverse an opioid overdose through community partners. There's been a significant increase in demand for that drug. And so we're requesting an increase. It's $2.38 million increase. It is all special fund, but the proposed funding is $400,000 from the Evidence-Based Education and Advertising Fund, and then $1.98 million from the Opioid Abatement Special Fund, which is the settlement fund.
We're hearing scary things about the naloxone dosage that's sometimes taking to prevent death.
Minimum of 2 doses in the era of fentanyl, for sure. And we are trying to distribute naloxone in novel ways and even more expansive than what we've already done. Literally flooding the streets with naloxone, making sure everyone has access to it. So it's still the cornerstone of harm reduction, even though there's many other things to be done. It's still the foundation. But we can.
On that note, I guess we'll move on
Yeah.
to what would be next? Substance use programs?
Almost there.
Yep, we can move on to substance use programs. That starts on slide 37. So again, same items that we've seen in both of our previous appropriations regarding the routine changes to our budget. There is the first line item under the grants major object in substance use programs is a change in funding for the recovery center. So this is just confirming a portion of their funding from general fund to GC investment. That's a net zero line item.
But that stays general fund.
Yes.
I went somewhere else.
We do that a few times.
I'm sure you do.
We're the heroes.
Okay, so the next line item in the grants major object in the substance use programs appropriation is a realignment of the state fiscal year 23 base appropriations. This is essentially a change in funding mix for substance use disorder treatment. We recognize a need to really support the residential treatment providers due to increased cost. So we're budgeting about $1.6 million, leveraging a portion of Medicaid to be able to increase the amount available to those providers. So budgeting about $1.6 million for that, and then about $950,000 for treatment expansion.
So that by doing that, how much more will you have available to spend in those areas? You're taking out
27%
what? 27% increase
by doing the GC.
for treatment, residential treatment and prevention.
Yeah, to put this into context for you, you know, you've heard about how traumatic the pandemic has been for the whole healthcare system, writ large, and workforce for sure, but the whole system. In substance use disorders, we have, of course, in Vermont, the hub and spoke system. That's the cornerstone of what we do, what we're famous for. But for some people, they begin in a residential facility, of which we have 3. Residential facilities were especially
So one's in
hard.
Rutland, one is Valley Vista, and the other's Jenna's house. Those are
Valley Vista and
Serenity.
Serenity.
That's in Rutland.
Right. So what's happened to them during the pandemic? Because they are like healthcare facilities, they had periods of time where they had outbreaks, couldn't admit new people, had to isolate people, etc., disrupted their programming. There were also the workforce issues associated with illness at the work site. And then there was the workforce issue called traveling nurses, which you're very familiar with, which impacts any facility that has healthcare personnel. So these facilities had the same issues. So they could never reach the bed capacity that they needed to. for their financial stability. And still haven't gotten there, to be honest, with regard to the cost of this healthcare workforce. So part of this realignment is to really focus on them and try to provide them the level of support they need to run at full operation, so people aren't waiting to get into them and can get the full services they have to offer. But at the same time, we don't want to compromise what some of the other money is supposed to go towards, like sobering beds, like lower level residential beds, like recovery residence programming, and new capacity in some of these existing facilities. So it's really an increase in money is able to both help the solvency of the current facilities and do these extra things that have to do with treatment of substance use.
I'm sure, are you a health department? The reason I'm asking is trying to relate what's here with what we had for requests yesterday. And that was
Yeah.
1.8. And is that additive, that's
Yeah.
what here, or is it in support of what's here and then $1 million more for the treatment beds? So.
Are you talking about what you were asked for the recovery
Yes,
community?
yes.
This is completely separate from that.
So this would be, they're asking for additional
Yeah,
funding.
they're asking for their 12 or 14 recovery centers throughout the state and the operation of them and the workforce for them.
This is for,
This is for residential beds.
All right, not the
Very
beds
different.
that they're talking about.
Right. These people will eventually want to have a good recovery program, which will then get them into what you're talking
Well,
about. This is not
Okay,
a line item on our budget that has anything to do with recovery centers.
okay, all right.
Oh, compared to this, we got the.
Well, I was just wondering, now some would come in and say, we support the governor's recommend for X, but obviously this is not the case here.
No,
And the other thing, of course, is we're looking at, is you look at, the impact of other systems on healthcare, and certainly mental health is right up there. And and that's been level funded. And so, in all honesty, that's a great concern because we're talking about a system that everybody says is in crisis. They're dealing with a workforce issue, they're dealing with inflation, they're operating facilities. And so the extent to which that system is strong or weak, obviously has a big influence. And, as we're looking at your factors that influence health.
so,
But that's for us to figure out.
but the mental health part of what we're doing is in the proposal you've probably seen regarding the blueprint,
Yes, but
because that's
I was gonna ask you about that, so.
Yeah, that's part of sort of
I
keeping
understand.
people from requiring the crisis level service in the emergency department, in the
I
hospitals.
understand the concept behind it, and I understand the investment. What I'm really concerned is that we've created a system that was designed to serve the most difficult to serve. They would have been served in an institutional setting a few decades ago. And so we can be making investments, and so you can't have a system that's being starved and asked to serve the sickest and most severely mentally ill or developmentally and intellectually disabled. And at the front end, we're adding more strength, but and I'm not debating that we've talked about integration of physical and mental health for years, but you still need to have, just like you need to have the ICU or you need to have
Sure.
special services. The last thing we want to do is to, as I said, I've used the analogy of we're adding more rooms on a system at the same time. Maybe our basic foundation is not as strong as it should be.
No, I completely know where you're coming from.
Yeah.
That, and the area of mental health you're describing is in the Department of Mental
I
Health
know,
budget.
I know that. I know.
is
that.
or isn't in the Department of
Yes,
Mental Health
yeah,
function.
yeah.
But not gonna.
No, but I'm just talking about, as you look at your slides and what you're talking about impacts health. A lot of the decisions we're gonna make around resources, in fact, have a direct
Yes.
impact on the very work that, you're doing.
No, I completely appreciate it.
So, yeah, and I know you're representing the governor's budget, and so, and decisions are made and whatever, but, so we've got our challenge ahead of us, but thank you for clarifying that what we're hearing, is in addition to that.
So the next line item in the substance use programs appropriation, the grant's major object is an increase in funding for substance misuse prevention. So we're on slide 41. The VSA section of 7909A directs that 30% of cannabis excise tax revenue shall be used to fund substance misuse prevention. The estimated amount, the 30% is about $1.41 million. So that's a general fund increase. This is going to be paired with a one-time appropriation, which you'll see on the next slide, of $1.59 million. There was a legislative intent established during the 22 session that a minimum of $3 million to be directed towards substance misuse prevention. So this base increase plus the one-time provides that $3 million for substance misuse prevention.
Okay, so
I was just gonna ask what the plan is for how that will be used.
Oh, good. So I can already tell you what we just did and what we will do. So for the initial, because this was a year ago in the budget, so 15 prevention coalitions across the state. I shouldn't say coalitions, grants to develop the coalitions were provided. So the whole model is sort of in the frame of Iceland model, if you recall that, and really having a regional prevention coalition based through CDC on a strategic prevention framework, so-called SPF, which really, we have great data in Vermont and the ones that have existed for several decades, showing decrements in uptake of cigarettes, alcohol, and cannabis in youth.
well, why do every health advocacy organization tell us how poorly we're doing
Well,
on smoking?
There's
I
an-
mean, everything we're hearing is,
there's
it makes
there's an
you-
equity issue because these coalitions weren't everywhere. And they were provided through federal grant funds, which were quite limited. So the wonder of last year's agreement with the legislature and governor for the $3 million was we can go statewide with this. So we had 15 grants we put out last year. Next RFPs, if you will, are out for our 12 health districts, making sure that we have that geographic equity that will allow communities throughout the state to benefit from this kind of framework.
then your epi data will be very helpful to those coalitions, because I imagine
Oh, yeah.
The challenges would vary perhaps by region.
For sure.
I don't know.
They do. And they also, it's amazing, you can do a graph of the impact of these grants on the communities. And then you can do it over 2 decades and look at the years that there was grant money and the years that the grant money didn't come through. And you see direct correlations between how the performance of these students is in terms of their uptake of these substances on the years that are good versus the years that there was no money. It's quite remarkable. So these work.
Well,
And this is ultimate wisdom to have done the 3 million originally. And this year, we're just trying to true it up, waiting for the additional cannabis money, to make up the difference. So the general fund will never have to do that again.
Well, that's
Well,
true.
there's good and bad to that, but, yeah.
On the other hand, because certain things that are really, I would say, really important to some of us are how we make investments directly with that individual at-risk youth. And so when we have mentoring programs or after-school programs, it's not, you don't hire, community prevention specialist to that, you're really building on volunteers and you're building on that human relation on an individual one-to-one. And so I hope that as we're looking at prevention, we're really looking at how we are making investments in that individual child's life, because that can make the difference for the rest of their lives. And I've been to some of the coalition meetings and I know that players are, and I know that they're paid professionals, but how does that translate down to the kid most at risk, who oftentimes isn't the one that's gonna volunteer to be in VCAT, for example, but really their lives would be changed by having that adult positive presence in their lives. So,
so having the after-school programming, having a mentor in an area of interest for the students,
absolutely.
All of that pays the dividends for sure.
So I hope when we're looking at those investments, we really put some attention, because we did allocate money for prevention, and I just think that the more we can do to provide that positive presence for some of these kids that are coming up in very difficult circumstances, or the behaviors they're experiencing, are just so important. But that's a tangent. I'm only expressing. I'm only expressing my view
Such a
about
good tangent.
in terms of
It's
prevention.
the whole point.
Well, I know, but we hire prevention specialists and we hire people to go out and there's, kids know who's doing something because they care about them.
Right.
Exactly.
They're not paid to do it, and they know, and oftentimes that's why it's the janitor or the bus driver that in fact is the person that's so important in their lives, because they do it because they know they care about them.
Right, and they get a connection to their community.
Absolutely.
Right.
So the theme again has been, this is more towards the adolescent part of life, but still a little younger. And everything we talked about earlier with the home visiting and the Dulce and the parent-child centers is focused on the very early part of life. So you really need it all in place as a continuum, but it works. I think we have one more slide to show you.
I like SPF.
Yeah.
The protection.
Right. Foster the protective factors and deal with the risk factors. Mitigate.
Okay, so we're on the last slide of the presentation, slide 42. And that just outlines the two one-time appropriations that the health department has. The first is the general fund addition for substance misuse prevention, which we discussed on the prior slide. And the second line item is the hub expansion pilot, about $4.6 million global commitment for that item.
So they're one-time appropriations, but it seems to me those are not one-time interventions. They're not a self-contained project. So really, are we talking about this is one time, but in reality, this is, in fact, should be an ongoing commitment?
So we'll talk about the hub one, because that's the one I keep referring to. The other one is really, even though that's a one-time appropriation, it's still
it's a
$3 million.
bridge. I understand it's a bridge to when the other revenue.
So the hub one, if you look at what a hub is in Vermont, a hub is in federal terms an opioid treatment program, or TP, which means you need an opioid diagnosis to attend the hub. However, the most common diagnosis at a hub, I would say, is polysubstance use, not just opioids. Also, it's so common, some people believe as common as 75 to 80% of the
I
time
believe it.
that there's co-occurring mental health disorders. Last but not least, many of the people we have attending hubs actually are doing well, but the attendance at the hub is actually onerous. They want to hold down a job, but they actually have to get to the hub, they have to get their medication, they have to get to their job from the hub, and they conflict.
Unless
right
you
there.
use Suboxone.
Even with Suboxone, if you're in an
You're not-
intensive
It's
outpatient
not daily
program.
though, is it?
No, I mean, Suboxone, you can be in a spoke and get it a monthly prescription, but you may also be in what we call an intensive outpatient program where you're in the middle zone. Either way, people with opioid disorder have complex lives. not only do they have mental health and other substances, they have other physical things, hepatitis C, sometimes HIV, sometimes they have history of incarceration, family members in incarceration, very complicated lives. Yet we're expecting them to pull it all together, so to speak. So our vision is, it would be nice if they could have what I would call one-stop shop, which means they could go to a hub, not only get their dose of methadone, if that's what they're there for, but if they have a co-occurring substance use disorder, have that managed by the hub as well. If they have a co-occurring mental health disorder, have that managed by the hub.
Well, in
If they
fact,
require treatment for hepatitis C, have that managed by the hub. And all of this is within the realm of possibility.
it sounds like a medical home.
Yeah, exactly, because they don't have time to go to 5 different medical homes
But-
and try to get their lives together.
But if there's one thing that we're getting, if people have expressed concern and that is where people, it's medication assisted therapy. It's
Yes,
assisted, it isn't the only, it's supposed to be accompanied by the very services you're talking about.
exactly.
And they're not accepting it, they want the medication. So our only, and we've had discussions about that, and the discussion is even medication by itself, even though
Still effective.
it's still effective because people are still functioning and able to
Right.
carry out their lives, but do you think, I mean, so in my mind, I'm thinking, gee, that's what the hub should have been doing anyway.
Right.
If you're really looking at MAT as it's supposed to be delivered, but some people don't accept it, so what will be the difference in
Right,
terms
so-
of acceptance?
So the hubs actually frequently, not less frequently, but frequently don't have the facility infrastructure to pull off everything I just talked about. They also don't have the healthcare personnel to pull off everything I talked about, or the training of the workforce to pull off all of that. So we're actually trying to do what you mentioned earlier, which is redesign a medical home at the site of the hub. Through some of the opioid settlement money, we've also talked about, just to get to that question, hublets, because as you know, there are people in certain parts of the state who say, hubs are too far, no matter which one I'm going to, it's way too far for me to go, it's a real challenge, and I can't do everything else in life and attend hub. So having smaller scale hubs that still do the same exact tasks is part of this as well. Because we have a pretty rural state, as we all know.
Mhm.
But I do agree with you, there's a population within the population who say, I want to get my medication and I'm done with it. But they do have other needs, and I think if they know that the other needs can be met at the same site, that's a bigger game changer than just saying, go to the GI specialist to get your hepatitis C medicine, go to your primary care to get your immunization, go to psychiatry to get your mental health, blah, 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 blah. That just
But
becomes
one would
overwhelming.
assume under the blueprint model, they already have a medical home. I mean, that was part of that whole, and the community
Right.
health teams.
Right, if they can
So
attend.
it makes, right, so it's just sort of like, how does this fit in with all the other structures already in
Yes.
place?
Right, so, well, but we had talked about expanding the blueprint model to include
Yes,
mental health.
so we're also,
So, yeah, so the question here is a good question. So is, if we're expanding the blueprint model, can we utilize those blueprint practices in addition to the hub practices?
only for the patients who are on buprenorphine.
Only for the-
And they do need a community, they need the team to support those patients. They say you
Yes.
have to have that team because the care demands, they're very difficult patients.
So it's two different patient,
It is.
Yeah.
Yeah,
So,
that's the,
unfortunately.
now, there may be an evolution
Yeah.
at the federal level and who could prescribe methadone and how that's done. That isn't happening overnight, but there's more and more movement to sort of meet people where they are. You know, we got rid of the waiver for the buprenorphine. You don't have to go through an 8-hour or 24-hour training. So this is within the realm of possibility, but not this year. You know,
all right, well, we'll see.
Did you want me to answer any more on this?
No, well,
Opioid settlement?
no, I have a very
Advisory committee?
specific question. I think I need to email you back because you emailed me about
Okay.
data related to, I'll ask it because I think it's important that many of the people who are transitioning back into the community after, during recovery, have specific needs, and one of those is perhaps dentures or dental.
Yes, yes.
And then, so can we utilize the opioid settlement funds for helping these folks access what they need so they can smile when they go to their job interview?
So the big answer would probably be yes, because as long as it's related to their opioid use disorder in a way, it's certainly not on the current list.
Well, drug
Because
use,
the current list is very harm reduction focused because we have a crisis of death
Can we add it to the list?
over the years, I would say.
Okay.
I would think there wouldn't be sufficient money this year to
Okay.
entertain it, knowing how much some of these things cost.
it's interesting,
I want to add it in as a perspective.
the impact on oral health.
It is, it's huge.
Yes.
You know, particularly the front teeth. You
Yeah.
notice,
That's it.
yeah, the front teeth.
Yeah, if you ever want a job, you've got to be able to present yourself.
But so the question is that the advisory committee has made recommendations and that, so that money will still flow through the appropriations committees in the House and the
That's right.
Senate.
But next week, the advisory committee's recommendations are getting assembled.
I guess,
They
and
go
then,
to me,
Yeah,
and then they go to the legislature.
right.
and
So,
the other dimension here is vocational rehabilitation.
Yes.
Because they in fact
Yes.
provide many of these same supports as a, just for employment, including dental.
Right, exactly.
So, so
So
that's
something to think about. I don't want to intrude in the
Yeah, no,
recommendations you're working on.
yeah, no, all thoughts are good thoughts. It's just that the thoughts that
The
our
thoughts are
highest
there.
priority right now are harm reduction thoughts that
Yeah.
lower the death rate from overdose. That's sort of where we are right now.
Okay.
There's going to be many more millions of dollars and just within the year.
Yeah.
So we're gonna have money to work with.
Oh, well,
Well,
that's,
I would put my plug in for that recommendation.
Yeah. Thanks.
other questions of Commissioner? No, for now, all right. Thank you.
Can you email me? We'll set up some time to sit down.
Yeah, he has the Department of Health.
Yes, we've worked together before.
Thank you. It looks like you've got to head out. Okay, 4:00. Okay, well, at that point, I think we completed our work for today, so I'm